Hello, everyone. I'm Gabrielle Tiet from the Montreal Children's Hospital.
Hi, and I'm Lara Leiser. I'm a staff neonatologist and assistant professor at the University of Calgary. And Gabriel and I will be moderators of this session, and we will start off with welcoming you to this session on neurohemodynamics and the application of near-infrared spectroscopy. So for this session, we have a great lineup of 4 distinguished speakers, including Dr. Valerie Chock, who will be presenting on cerebral NIRS. Then we have Dr. Zach Vazoulis, who will be presenting on cerebral autoregulation, Purva Despani, who will be presenting on hemodynamics and cerebral injury in preterm infant, and finally Regan Giesinger, who will be presenting on HIE physiology. So we have the 4 presentations first, followed by a long Q&A session. So we would like to ask you to put all your questions, including the speaker's name, in the Q&A box, so we can ask the questions at the end of the sessions, and we will try to make sure all the speakers get their questions and all your questions will be answered by the speakers. Over to you, Gabriel.
Thank you, Lara. So we'll start with our first speaker, and it's really a great privilege and honor to introduce Dr. Valerie Chock. She is an associate professor of pediatrics at Stanford University and associate director to the Neonatal Prenatal Consultation Services at Lucille Packard Children's Hospital. Her research includes investigation of altered hemodynamics and regional tissue oxygenation for infants at high risk for central nervous system injury and neurodevelopmental impairments. And we are very privileged to have Dr. Chock, who's been one of my mentors, at least, in teaching me so much during my stay at Stanford. So Dr. Chock, please, we're very happy to have you.
Thank you so much, Gabriel, for that kind introduction. And really thanks to the organizers of this course for inviting me to be a speaker. Let me just make sure that I can share my screen appropriately. All right, do you folks see the starting slide, or do you see the title slide? Is that good? Okay, perfect. All right. So I'm going to start off by saying that if you're interested in hemodynamics, which I'm assuming all of you are since you're attending this course, you need to become familiar with NIRS monitoring. In my opinion, it is a powerful tool that currently is really the best, provides us with the best insight into cerebral oxygenation and perfusion at the bedside in real time. I've had about 17 years of experience using NIRS in the NICU, which for us started off as a research tool only, and then has since evolved into a technique that we use at the bedside to help guide clinical decision-making on a daily basis. So I'm excited to kind of share that journey with you. If I can advance my slides. Okay, I have nothing to disclose. So there are a number of different bedside monitoring devices for babies in the NICU that measure physiologic parameters. However, up until recently, end organs like the brain were forgotten. So near-infrared spectroscopy, or NIRS, was developed as a way to monitor tissue oxygenation, and specifically in this case, brain oxygenation. And we're going to first review a little bit of how it works. So again, NIRS is a continuous, real-time, non-invasive bedside monitor of regional tissue oxygenation, which is often abbreviated as RSO2. You can see a sensor on a baby's forehead measures the underlying oxygenation of the brain. This has been validated with jugular venous SATs and FDA approved for use in babies, including those babies that are less than 2.5 kilos. In principle, very similar to a pulse oximeter. A sensor is placed on the skin, and near-infrared light is emitted, penetrates through the underlying skin, bone, soft tissue to a depth of about 2.5 centimeters. And there it is differentially absorbed by oxygenated and deoxygenated hemoglobin in the tissue. Light is reflected back to a detector on that same sensor, and then a tissue oxygen saturation level is calculated, reflecting the underlying arterial and venous blood, typically heavily venous weighted, so approximately 75% venous, 25% arterial, and again, reflecting the balance between oxygen delivery and consumption in the underlying tissue. Here you have pictures of what this looks like at the bedside. You have a sensor, the NIRS sensor on a baby's forehead, measuring cerebral oxygenation. Typically, we like to do 2-site NIRS monitoring. So the somatic site that we most frequently use is the renal location. So here's a picture of a renal sensor on the posterior flank. But the reason why we do 2-site monitoring is that circulatory impairment tends to reduce your somatic saturation first. So really, it's an earlier indication of hemodynamic compromise. I'm really not going to speak about somatic site monitoring today, although a lot of interesting work is being done in these fields, particularly renal and intestinal oxygenation. So let's transition now to talking about cerebral hypoxia thresholds. And this is a pretty popular graphic that's been shown based on a large European study looking at preterm babies and population norms, so looking at the 95% confidence intervals of what cerebral saturation is, and this is typically between 55 to 85%, which is this green zone represented here. So when a baby falls into more this yellow cautionary range, so this is typically cerebral sats less than 50%, a provider typically gets called to the bedside to assess what changes need to be made to address cerebral hypoxia. So I'm going to show you why this is important and why adverse outcomes are associated with these red zone, this lower range of cerebral hypoxia. Keep in mind that term babies tend to have a higher range than preterm babies. And then values differ by sensor and device type. So this study was based on using adult sensors. Neonatal sensors tend to run about 10% higher, but I do think that this typical 55 to 85% range is still very valid, and I'll talk about that in a little bit. And then just emphasizing that the trend over time for an individual baby is more important than the absolute value, although we do have to be cautious when the value falls too low. So here's an example of a piglet model where cerebral saturation in these piglets were held less than 40% for at least half an hour, and that's where you start seeing cellular injury. These are micrographs of the hippocampus of the brain, and you start seeing mitochondrial injury, swelling, and then fragmentation of the Golgi and endoplasmic reticulum. So again, cellular injury that occurs for low cerebral saturations. From a neuroimaging standpoint, we actually start seeing ischemic changes in the brain as well. So this was a study of babies with hypoplastic left heart syndrome. And in these babies post-operatively, you can see some periventricular white matter characteristics of ischemia from hypoperfusion. And this was seen in those babies who had a cerebral saturation less than 45% for a cumulative time over 180 minutes. We did an observational multicenter study looking at the preemie population, and similarly found that for those babies that were monitored with NIRS the first 96 hours of life, those who died or who had severe IVH by cranial ultrasound also had lower cerebral saturations. And in fact, we found a cutoff of 50%, less than 50% being associated with adverse outcomes. And then when you look at neurodevelopmental thresholds, again, we go back to our hypoplastic left heart syndrome population. There have been reported abnormal visual motor integration skills at 56 months of age for these babies that have had their cerebral sats less than 45% for at least an hour of time. And then again, switching over to our preemie population here, we can see in this large study of over 700 babies that those who died or had poor cognitive outcome at 24 months by Bailey exam, and they had a lower cerebral saturation in the first 72 hours after birth, as represented by this dotted line, compared to those with better outcomes. And in this study, they found a cut point of 55% being associated with adverse outcomes. So I've showed you all these observational studies that have looked at adverse outcomes being associated with cerebral hypoxia. But I think kind of what the holy grail is can we make a difference? And this is what some of our interventional NIRS studies are trying to get at. Does maintaining a targeted range of cerebral saturations using a treatment guideline actually make a difference to improve outcomes? And one of the biggest studies to look at this is the SafeBoost-C trials, which some of you may have participated in. And this has been targeting this range of cerebral saturation between 55 to 85% per that original graphic I showed you versus standard care alone. And the first iteration of this study, the intervention group was found to have a lower burden of cerebral hypoxia, as would be expected if you're trying to maintain a targeted saturation. The larger SAFU-C3 trial with endpoints of mortality and cranial ultrasound outcomes was recently completed and it's pending publication, so I'm not going to speak about that today. But I will talk a little bit about our similar brain oxygenation, which we've dubbed the BOX trials, which myself, Zach Vassilis, who's our next speaker, and a few others have been putting together. This is a multi-center study of extremely preterm babies using NIRS in the first 72 hours of life to maintain this targeted cerebral saturation, as we've shown here. And we're specifically focusing on endpoints like brain injury on MRI, what specific interventions are actually being used to address cerebral hypoxia if we fall below target range, and the relationship of cerebral SATs with systemic SATs. Just briefly to kind of demonstrate to you, this is the box treatment algorithm that we've developed, very similar to the SAFU-C trials, where if you fall outside of range, providers are instructed to look for variables that affect cerebral saturation, like hypocarbia, hypoxia, hypotension, anemia, and to consider making these changes, these interventions, to get back into a normal range. I'm not going to spend too much time here because this is exactly what we're going to talk about next, the approach to abnormal cerebral NIRS. Okay, so this is basically an important slide. So if you've kind of fallen asleep, this is when you want to wake up a little bit to just remember what do you do if you get called to the bedside and your cerebral saturation is low. It's less than the 50% kind of threshold range. I always tell people to remember the main 4 physiologic variables that affect cerebral saturation. So number 1, is the baby overall hypoxic? Is this baby have a low systemic SAT? And is this someone that maybe you need to turn up the FiO2, for example, or address the hypoxia? Secondly, we know that cardiac output contributes to perfusion of the brain, and blood pressure being a surrogate of cardiac output. Is this baby hypotensive? Could this child benefit from something like fluid resuscitation or initiation of a pressor? Number 3, oxygen carrying capacity. Is the baby anemic? And we've been developing some transfusion guidelines based on low NIRS values. I'm not going to talk about that, but definitely anemia is something to consider in a baby with low cerebral saturations. And then number 4, oftentimes people forget about the powerful impact of carbon dioxide on the brain. So if the baby hypocarbic, we know that low carbon dioxide levels result in cerebral vasoconstriction. So perhaps this is a baby that we need to adjust the ventilator settings to actually bring the CO2 back into normal range. So those are the main 4 physiologic variables that I always ask people to consider if your cerebral saturation is low. There are obviously still a few other things that don't occur as frequently. I did mention that cerebral SATs are a balance between oxygen delivery and consumption. So if the cerebral metabolic rate is high, that could be contributing to the problem. So things like thinking about sedation, controlling hyperthermia. And then finally, there are other underlying conditions that affect cerebral saturation, which probably some of the other speakers today will address, but conditions like severe IVH, hemodynamically significant PDA with impaired autoregulation, underlying congenital heart disease, or direct hyperbilirubinemia. This is something people often forget. Conjugated bilirubin is a chromophore that will absorb near-infrared light and can decrease your cerebral saturation. On the flip side, we can have cerebral SATs that are too high. As you recall, we said the normal range is roughly between 55 to 85%. So what do you do if your cerebral SATs are over 90% for a sustained period of time? So kind of think the opposite of what I just talked about. Maybe there are supernormal arterial SATs and it's time to wean your FiO2. Hypercarbia can cause cerebral vasodilation, leading to higher cerebral SATs. So maybe this is a child where we need to increase ventilatory support. And maybe this is a baby that is not extracting oxygen. So sedation might need to be weaned. Baby might be hypothermic. I think Reagan in a little later is going to talk about the HIE population, but this could indicate a poor prognosis in babies with HIE, whose brains are not extracting oxygen. And then there are some conditions with redistribution of blood flow to the brain. So babies that are growth restricted, or babies that are hypoglycemic because glucose is the primary fuel of the brain, might have higher sats just because of blood flow redistribution to the brain. Okay, so here's a case example. We have here a 27-week preterm baby who's 1 week old. You can see in this graphic of the NIRS monitor that there was a drop in the cerebral sat from 70% down to 40%. So you get called to the bedside and wonder what's going on, what could have caused this. So of course, we go back to thinking about what are those four main variables that affect your cerebral saturation. So could this baby be overall systemic, have low systemic sats? Is this baby hypoxic? So could this baby have accidentally extubated and therefore had a severe prolonged desaturation? Yes, that could be an explanation of this drop in the cerebral sat. Then you think about cardiac output that we talked about. Could this baby be hypotensive? Maybe the bedside nurse had just changed out the dopamine syringe, and because of that, we are having problems with infusion of the pressor. So yes, that could also explain this scenario. We talked about hypocarbia, and maybe this is a child that just got surfactant and is on a mode of ventilation where we weren't able to wean quickly enough, and this baby is hypocarbic. This could have also caused this dip in the cerebral sat we see here. And then finally, we talked about anemia. Maybe this baby had a pulmonary hemorrhage, which caused this change. This is actually the answer to what happened in the scenario. We gave some blood and the cerebral sat came up nicely after that. And obviously, you would see if a baby was having a pulmonary hemorrhage at the bedside. You don't need the NIRS monitor to tell you that, but I think it's just a good example of how to address or how we really see changes impacting, or how do we assess low cerebral saturations at the bedside and what can impact that. And then I'll finish my last example that I really like to show people. This is a post-dates baby who was on VA ECMO support for severe pulmonary hypertension and meconium aspiration syndrome. He was 8 days old. He had been actually doing really well on ECMO. They'd been weaning ECMO flow, but you can see here this drop in the cerebral sat and a corresponding drop in the renal sats over time, over about 24 hours. And what was surprising was there weren't any other signs of distress. There was no tachycardia, no hypotension, the mixed venous sats and the blood gases were stable. The central venous pressure didn't change. There was no lactic acidosis, no anemia. So really nothing that was explaining why there was this drop in our cerebral saturation. But because we're a center that really believes in NIRS monitoring, we decided to explore this a little bit further. What we did is we got a targeted neonatal bedside echo, despite this baby being hemodynamically stable. And even I, who am not a cardiologist, can see that this is not normal. There was a large pericardial effusion around the heart. They proceeded with a pericardiocentesis, and this was followed by an uneventful ECMO decannulation. So I always like to kind of talk about the scenario because in this case, NIRS monitoring detected a problem really before there was any clinical indication that a problem even existed. So it's just a powerful example of how NIRS monitoring can be beneficial. Okay, so I'm going to finish up now with talking about a little bit about implementation of NIRS in the unit and some limitations. So exposure is the biggest thing. If you're a center that wants to start using NIRS monitoring, I mentioned that we started off with using research studies, and then we focused in on a targeted population, babies with congenital heart disease, and then babies who are being cooled for HIE. And now, we've expanded it to use as a routine neuro NICU monitor at the bedside. And so our group, as well as many others, have a targeted population of babies who get cerebral NIRS monitoring. I think that's helpful. So for example, we monitor preterm babies less than 29 weeks gestation for the first 7 days of life, or if there's concern for a PDA or severe IVH. We also monitor term or preterm babies with congenital heart disease, severe respiratory failure, pre-ECMO or ECMO babies, babies with HIE, and really anyone who are concerned for adequate cerebral blood flow. So I think you'll hear my colleagues discuss NIRS use in some of these patient populations in more detail in the next few talks. So I like to also remind people that there are limitations to NIRS monitoring. I kind of mentioned earlier the variability in absolute values between different devices. And I just like to tell people to learn how to use one device well. I also like to mention the depth of signal penetration. So this is limited to the cerebral cortex. We don't really know about how the deeper structures in the brain are being affected. It takes up space on the baby and at the bedside. There is cost involved. And importantly, there's a need for ongoing provider education. I'm really impressed that we've empowered our nursing staff to talk about NIRS on rounds. It's reported as one of the vital signs, in fact, and really discussing as a group on rounds, like, what is the NIRS monitoring telling us physiologically about this baby? Do we need to make any changes based on it? We have some annual certification, including a yearly quiz and an educational module that nurses, fellows, nurse practitioners, attendings all take on a yearly basis to kind of refresh their skills. And we do case reviews and didactics on a regular basis. So it's important to really pay attention to the numbers, because otherwise it's just one more piece of data at the bedside that no one's paying attention to. So it's really vital to incorporate that into the daily discussions. And then I always like to have a slide about skincare, especially in our preterm population. We use Nepitel dressing that gets placed under the adhesive of a NIRS sensor, so it's a little gentler on the skin. We like to avoid direct pressure over the sensor, because I have seen pressure injuries from maybe like a CPAP device that's resting too firmly on the sensor. We try to maintain creative ways to keep the sensor in place, like headbands or bows, because sometimes in the humidity of a high humidity environment in an isolette, the sensor can fall off. And then always emphasizing that having NIRS monitoring in place is not a barrier to holding. We really encourage skin-to-skin kangaroo care by parents, even when babies have a NIRS sensor in place, just like having any other sensor on. And then my final slide, just talking about future directions for where I think brain tissue oxygenation monitoring is going. I think we're going to move towards smaller integrated wireless sensors, expanded use of NIRS in other tissue beds and additional populations, as I've listed here. And then finally, data synchronization is going to be key. Multimodal monitoring and machine learning algorithms for prediction, I think is where the field is going to go. So I kind of went through everything really quickly, but thank you so much for your attention. I want to thank the Stanford Neuro NICU team, and I think we'll hold questions to the end of this session.
Indeed. Thank you, Valerie, for this very clear and clinically relevant overview of the use of cerebral NIRS. And I'm amazed to hear that you have been able to integrate it so well in your clinical care. We're here in Calgary, we're still making baby steps when it comes to that. As said, indeed, we will be leaving the questions for last or the end of the session. So I would like to remind the attendees to put their questions in the Q&A box and in the chat, so we can try to answer them all at the end of the session. But for now, we will move on to the next presenter, and that will be Dr. Zach Vasulis. He's an assistant professor in the Department of Pediatrics, Division of Newborn Medicine at the Washington University, and is the co-director of the Neuro NICU program at the St. Louis Children's Hospital. His research interests include computational modeling of high-resolution multimodal physiology to eliminate mechanisms of brain injury and in term and preterm infant. So a mouthful, but today he will be presenting on cerebral autoregulation. So Zach, the floor is yours.
Thank you so much. I really appreciate the opportunity to present some of our work as well as many others. And then also for the excellent talk by Dr. Chock, which I think really sets the stage for this. Stanford really is an excellent example for all of us of the best way to implement NIRS program clinically. So my talk is focused on what Dr. Chock mentioned at the end. This is the very end of my slides here. This is all about integration of different signals, different vital signs to really start to understand the mechanisms of what's going on inside the brain. And when we're talking about brain injury in neonates, autoregulation is the key part of that. So I have some disclosures on this slide. Like I mentioned, the point of this discussion is understanding the physiologic basis of autoregulation, describing some of the mechanisms as far as we know about blood flow autoregulation in the brain, and then how do we actually quantify that in babies. I'm going to go through a number of different approaches that have been used to do that and talk about it in both a normal state as well as a pathologic state, and then sort of bring it all back together and talk about next steps. Where do we go from here? So this is a figure that's similar to probably what most of you learned in medical school. This is the cerebral autoregulation curve. This is not new. So this was first described by Lassen in 1959. This has been around for quite some time now. And it's this overall idea that cerebral blood flow should remain stable in the brain. Our blood pressure fluctuates up and down, our positions change, you know, if we're sitting up, standing up, laying down, and our body needs to be able to adjust the amount of blood flow to the brain to maintain constant perfusion. So that's what's demonstrated by this plateau here, this flat spot in the middle of the curve. And we know from Lassen's work and many others who have come after him that there is a lower limit to this. When our blood pressure becomes too low, our cerebral blood flow can't keep up with the metabolic needs of the brain, and we start to have impaired perfusion. This is somebody who's severely dehydrated, for example, who is sitting down and then suddenly stands up and feels lightheaded. This is that part of that curve right there. There's also the same issue on the other side of the curve where our blood pressure is too high and our cerebral blood flow becomes unregulated once again and starts going up as blood pressure increases. And this is territory, particularly in adults, where we start to worry about things like subarachnoid hemorrhage or strokes. So while many of these features are understood well in adults, in babies, especially preterm babies, we have no idea what these limits are. We know that this exists in preterm infants, that they do have cerebral autoregulation, but exactly where these limits are, how common they are from baby to baby, is something that's really a very active area of investigation right now. So what is cerebral autoregulation? So the goal of the autoregulatory system in our brain is to maintain sufficient oxygen delivery for maintenance of metabolism. That's really its entire goal. And in an optimal situation where there really were no extrinsic or even intrinsic factors going on, the only changes in cerebral blood flow would be driven by metabolism, by our brain becoming active in one way or another and needing more oxygen to do that metabolic activity. Now that's not realistic. Our bodies are under many sources of stress, especially our preterm infants. And there's a lot of other factors that can influence cerebral blood flow. Carbon dioxide is a big one. So if your CO2 level gets too low, it causes vasoconstriction and you have a reduced cerebral blood flow. Or on the reverse side, if the CO2 is too high, we can have a lot of vasodilation and hyperemia. Many different medications, especially sedation medications, can cause changes in cerebral blood flow, changes to our systemic blood flow. So if something happens and there's impaired cardiac output, like Dr. Chock's example with the pericardial effusion influencing our cardiac output, that's going to change our cerebral blood flow. And then, of course, also the position. Are we flat? Are we sitting up? Are we standing up? Which is less of a factor for our babies. So underlying all of the mechanisms that control the cerebral blood flow are really three factors. One is called the myogenic response, another is the neurogenic response, and the third is metabolic. And I'll go through each of these examples. So neurogenic control is a part of all blood vessels in our body, especially our brain. Our blood vessels are lined with adrenergic receptors. It's all part of our sympathetic and parasympathetic nervous system. And these receptors bind to catecholamines. So those are our endogenous ones produced by our body, like norepinephrine or epinephrine, but they also respond to medications that we give patients too, dopamine, phenylephrine, and so on. So when catecholamines bind to these receptors, it causes changes in the vasodilation versus vasoconstriction. And it's a balance between these two things that should be driven entirely by the needs of the baby. There are many different subtypes of these receptors that have been identified. The alpha and beta classes are the most common ones, especially in blood vessels in the brain. And two of the most common responses that we think of that I've already talked about are the baroreceptor response, so changes in blood flow in response to our blood pressure, big changes in cardiac output, as well as chemoreceptors, things like carbon dioxide levels. These are all driven by the sympathetic nervous system. It is this neurogenic control that causes vasoconstriction and vasodilation in response to these stressors. The second type of mechanism is myogenic control. This is a stretch response. So when there is increased intravascular volume, and that could be from a fluid bolus that you're giving to a patient, changes in cardiac output. In either case, the blood vessels stretch because of all this extra fluid, this extra volume that's in there. The smooth muscles stretch, and there's an influx of calcium into the membranes, and that causes vasoconstriction. All that calcium entering those myocytes causes them to constrict, which increases resistance to blood flow. So that's a response, a stretch response. This is purely mechanical to hyperemia. The reverse is also true. So when there is limited volume inside the blood vessel, there is very little calcium influx, which causes those myocytes to start to relax and the blood vessel to dilate, and an increase in blood flow. And then the third mechanism that's at play here is metabolic control. So we know from some really nice MRI studies that have been done by many groups and a lot of different patient populations that blood flow is not constant throughout the brain. It's not just coming through the anterior or middle or posterior circulation, but rather is driven at the arterial level by the metabolic needs of the brain. And we can actually see for MRI bold imaging, for example, like shown in this picture here, that it's very dynamic, that depending on what's going on with the brain, blood flow will increase or decrease in different parts. That is driven really at the level where the cerebral cortex interacts with arterioles. So when you have sustained metabolism, there's a lot of metabolites that are produced in response to that. Some examples are adenosine, carbon dioxide, again, potassium and lactic acid, and those are vasoactive substances. So the byproducts of metabolism itself cause either vasoconstriction or vasodilation, depending on their concentration levels. And this is how part of the brain can drive increased blood flow to that region from metabolism itself. So those are all the different mechanisms that are hypothesized to go into cerebral autoregulation, but these are not things that we can measure directly. You can't measure the myogenic response or the neurogenic response. And in fact, we can't measure autoregulation itself directly, but what we can do is measure it indirectly. So if we think of it as a black box, we can look at the input to this system, which is our blood pressure that's shown on in blue on the left here, and then the output, which is cerebral blood flow. Cerebral blood flow is difficult to monitor continuously in anyone, much less a preterm infant. The MCA, the diameter of the MCA is quite small in a 24-weeker, and you can't keep a Doppler, cutaneous Doppler probe there forever. So NIRS is a really excellent alternative measure that's highly correlated with cerebral blood flow. And Dr. Chock went through a lot of great detail supporting that. What we are looking for, though, is how this autoregulatory system changes that input signal. So if we have this fluctuating blood pressure, we should see something that looks like the green line here, where the blood flow is driven entirely by the needs of the brain, and it does not resemble the blood pressure at all. When autoregulation is impaired, it starts to look much more like the blood pressure, and you can see the spikes up and down that are going in line with the spikes in blood pressure. So how do we quantify this? That's a very subjective measure that I was just talking about. Well, it turns out there's lots of different ways to do this, and I put it in red here because I think it's important. There's absolutely no standards with this. There's not one particular method that's accepted by everyone as the definitive approach. So I'm going to talk through a number of different examples. The nice thing about these, even though they're not the same methodology and the numbers themselves are not the same, for babies, especially our preterm babies, they're all telling the same story. They all match with one another on a big picture level, which is good. That helps us to understand and confirm that these mechanisms are really going on. So the first one that I'll talk about is the simplest. It's time domain correlation. This was developed at University College London, and it truly is the correlation between the blood pressure signal and the cerebral blood flow. They originally used transcutaneous Doppler ultrasound and then eventually switched to NIRS signal. And the idea is that if there is zero or negative correlation between blood pressure and your NIRS signal, that autoregulation is intact, that's a sign that it is functioning properly. If there's positive correlation, however, that's an indication that it's impaired. So they divide up their recordings into these 10-minute windows, calculate these correlation values, pair them up by the blood pressure, and then look at the resulting curve. And I'll show a picture of that on the next slide. If you collect enough data with this approach, you can actually start to identify the optimal blood pressure. That's the blood pressure at which this correlation is the most negative. And you can see this overall curve that starts to be developed from that. In the papers that they originally wrote, as well as many that came afterwards, they've described this optimal blood pressure and deviation from this blood pressure being associated with death in some patient populations or brain injury in others. So here's a paper that was published using this approach, and you can see here's the blood pressure right here. This is a neonate, a term neonate, and here are these correlation values. And in red here is the optimal blood pressure. So at a blood pressure of just about 32 millimeters of mercury, the correlation coefficient is the absolute lowest. But when the blood pressure starts to get too low, the correlation rises. And when the blood pressure starts to get too high, it also rises. And under here is just a histogram of how much time was spent at each one of these blood pressures. We did a very similar study just to give an example with some example patients in babies with HIE. So this is the same sort of figure made a slightly different way for one of the babies in this particular study. And you can see that when the blood pressure starts to get too low, this correlation coefficient actually flips to being a positive value. And then the same thing happens on the right-hand side of this curve where it becomes positive. If you sort of imagine this curve representing the flat part, that plateau of our autoregulatory curve earlier, and then the left and right-hand sides representing the loss of autoregulation on the other side, you can see how these two things are really describing the same phenomena. So in this group, we took 16 babies with HIE, calculated these values. For each one of the babies, we figured out where this high and low transition occurred, and then averaged it across the group and came up with a lower limit of about 47 millimeters of mercury and an upper limit of about 55.5. And then we plotted this out over time. So for babies that we found MRI injury are shown in blue here, and those that didn't have any injury on MRI are shown in red. And then we looked at what their blood pressures were after defining these upper and lower autoregulatory limits. And consistent with some of the previously published literature in preterm infants, we found that the babies that did not have injury spent their entire time with their blood pressure between the upper and lower limit, but those with injury spent time, especially on that third day, and all of these babies were cooled, with their blood pressure outside of that autoregulatory limit. And that's shown a different way in the box and whisker plots right here. The question, of course, is what's the chicken and egg here? Do we have impaired autoregulation that's leading to brain injury, or do we have brain injury that's causing impaired autoregulation? That's a question that still needs to be answered. Another strategy that's related is something called coherence. So this is the same idea of correlation, but in this setting, we're not looking in the time domain. We're not looking at the values of the blood pressure or the NIRS themselves, but instead we're looking at how they vary. So if you think of all signals collected from humans as these complex squiggly waveforms that are really just a bunch of sine waves that are all interposed on top of each other, you can use a computer to calculate how much of these oscillations or vibrations in those signals are occurring in different frequency bands. And when you look at really low frequencies, so between 0 and 0.4 hertz, for example, those very low frequency oscillations are actually autoregulation in action. Depending on how strong those oscillations are, you can get a sense of how active or inactive autoregulation is. This figure comes from a paper published by Janet Soul in the Boston group from a number of years ago now, where they looked at preterm infants and their autoregulation by day after birth. So this is the first, second, third, and so on day after babies were born. And they defined babies as being pressure passive, which is another term for impaired autoregulation, if this coherence was greater than 0.5. So unlike correlation, which goes between -1 and +1, coherence only goes between 0 and 1. So if there's 1, if the coherence is 1, that means there's 100% concordance between the NIRS and the blood pressure signal, which means absolutely no autoregulation whatsoever. If it's 0, that means there's no relationship and highly intact autoregulation. So they found several surprising things. First, that all babies had impaired autoregulation. It wasn't really a matter of a baby being impaired or not impaired. All babies spent about a fifth of their time in a pressure passive state. But the degree of pressure passivity was very strongly linked to lower gestational age infants, so the more preterm, as well as sicker babies. This has also been done by the group at Children's National and an HIE population. They took the same approach with coherence. They've defined a threshold here of 0.4. They used a slightly different threshold, but found babies with favorable outcomes spent their entire time with coherence under the threshold versus those with unfavorable outcomes above the threshold. And then the final model I'm going to talk about is called the transfer function approach. This is something that we've worked on here. And this is looking at oscillations. So we're talking about low frequency oscillations again, but we're looking at a response to these oscillations. So the oscillations start in the systemic blood pressure. Autoregulation should dampen them. It should smooth them out. We don't want spikes, oscillatory spikes in cerebral blood flow. So you can think of it as a volume knob on a stereo system. The autoregulation should be turning down these oscillations, particularly where they are very strong. So in this study, we used a bunch of preterm babies, took mean arterial blood pressure and NIRS samples, and we looked at oscillations, particularly in this frequency band between 0.5 and 0.1 hertz, where these oscillations are very strong in systemic blood pressure. And you can actually see that there's a notch here. So increasingly negative values show you the dampening ability, how much this volume knob can be turned down. And babies, as they are more and more mature, have stronger and stronger dampening around this frequency band where these oscillations are the strongest. So this really, if you think of it more from an electronic standpoint, is a high-pass filter. So this autoregulatory system is filtering out oscillations in this specific frequency band. The body recognizes that there's oscillations there, and it's filtering them out. And the developmental stage of the baby indicates how effective that filter is. We looked at this in injury states, and it turns out babies that have IVH have less dampening at that particular frequency band than the babies that don't have IVH, and perhaps an indication of mechanism. Again, is this a sign that the baby has had injury and is impaired autoregulation because of the injury, or is it the cause of the injury? So just to put all this stuff together, this is a very different use of NIRS than what Dr. Chock talked about. These are all research metrics. This is not something that's available on a commercial device, but we are all very optimistic that we'll start to see these things soon. This will be taking multiple signals, so the blood pressure, the pulse oximeter, and the NIRS, combining them together to understand mechanisms where we can both see the need for treatment as well as the response to the treatment. Now, there's a lot of questions about exactly how these metrics should be put together, what should be included in them, what thresholds should we use. That's a big area of active discussion, which is why this is still a research topic. But it really begs a question about all the right ways to respond to these impairments that we see. So I'd like to thank the whole team here at WashU for all the help that they provide in these studies, as well as acknowledge all of the sources of funding that went into this.
Dr. Vizoulis, thank you so much for an outstanding presentation. I'm sure it will elicit a lot of questions. It is really my pleasure to present the next speaker. So we have with us today Dr. Purva Deshpande. She is a staff neonatologist at Mount Sinai Hospital in Toronto, Canada, so a fellow Canadian of mine, and an assistant professor of pediatrics at the University of Toronto. Her research interests are in the field of cerebral hemodynamics of intraventricular hemorrhage, combined multimodal brain and hemodynamic monitoring, as well as neuromonitoring in preterm infants using near-infrared spectroscopy and amplitude integrated EEG. She will be presenting to us on the on the hemodynamics of cerebral injury in the preterm infant. Thank you so much for joining us and for sharing it with us, your expertise, the floor is yours.
Great. Thank you so much, Gabriel, for this very kind introduction. I'm just going to share my slides. Let's see if this works. Can you all see my slides? Okay, perfect. Okay, so I also want to thank my previous speakers, Dr. Chock and Zach, for these kind of foundational talks that have really set the scene for this topic on cerebral injury in preterm infants. So what I'm going to really talk about today is the heart-brain connection, and I hope that I am able to demonstrate to you that one cannot really talk about brain injury without also thinking about the the systemic hemodynamic aspect. So brain health and heart health do go hand in hand. We know that the ultimate goal of NICU is intact neurological survival. So really the goal of having a happy heart is to have a happy brain. And so cerebral injury is a really broad topic, but what I'm going to really focus on today is on the hemodynamics of intraventricular periventricular hemorrhage. What I'm going to focus on are some specific developmental and physiological considerations in addition to the cerebral autoregulation that Zach has already covered. I will talk about some hemodynamic associations that we have learned from the literature, both from epidemiological studies as well as from physiological hemodynamic studies. I'll talk about the main mechanistic theories in relation to IVH that kind of are around the transitional circulation, which is a specific issue in the extreme preterm infants, and then I will also touch upon the role of the duct in IVH. So I think first of all, I just wanted to highlight and probably take from what Zach talked about the blood vessels in the brain, and really the germinal matrix, which is the vascular component. So there is the brain and the heart, but then the blood vessels in between, which I think over time have just grown a lot of respect for. During my short career in neonatology. So the germinal matrix in preterm infants is really quite different from that in older infants or in adults. And the analogy is that of an inner tubing of a tire as compared to the actual tire itself. So in preterm infants, it's only lined by a thin layer of flat endothelial cells as opposed to the smooth muscles and the connective tissue layers that are seen in more mature infants as well as in adults. And that's what makes the germinal matrix really, really vulnerable to any of those changes or in absence or lack of autoregulation and leading to hemorrhage. So we also know from histological studies that the germinal matrix is just dense in its blood vessel content, but also the blood vessels in the germinal matrix are histologically different to the blood vessels elsewhere in the brain, such as in the cortex or the basal ganglia. So they are truly really thin lined. They have a very little smooth muscle component, as well as a connective tissue component. Their basal lamina is not as strong, and they can just rupture quite easily in response to fluctuations in the cerebral perfusion pressure. And so I'm just going to just to wake the audience up, start with a question, a poll question. Why is IVH confined to the first week of life, irrespective of the gestational age at birth? People can just, post their answers. So the first is the PDA shunts left to right as the PVR drops during transition. IVH happens secondary to transitional hypotension. The germinal matrix rapidly matures after birth, and IVH happens at the peak of RDS severity. Okay, that's great. So we have majority of the audience that have said that the germinal matrix rapidly matures after birth, which is indeed the right answer. So what happens after birth is, as with the exposure to oxygen, there is a rapid downregulation of the vascular endothelial growth factor, which decreases this rapid angiogenesis in the germinal matrix, which then it decreases the fragility of the germinal matrix. And that's why we only see IVH during the first week of life, majority during the first 72 hours of life. So there are two popular theories on the pathophysiology of IVH, and I'm going to talk about each one of them. And then also kind of talk about some of the literature which either support or refute those theories. So let's first talk about the venous congestion theory. And this idea really came from the older studies looking at autopsy findings in babies who have had germinal matrix hemorrhage. And what that showed was that the germinal matrix hemorrhage was predominantly found in the venous areas of the brain or of the germinal matrix. And that kind of raised a lot of concerns about what we could be doing in the way we care for our babies, or any specific scenarios that may lead to increase in the venous pressure. And then we know that, over the last few years, there's been some interest in head positioning and, whether head tilting can cause increase in the jugular venous pressure, whether, things like mechanical ventilation and pneumothorax decrease the venous return, and therefore they may predispose to IVH. And indeed, this was one of the largest randomized control trial, which was done on elevated midline head positioning, comparing with the flat position. And they looked at the incidence of IVH, and indeed they showed that babies who were nursed supine with the midline positioning and an elevated angle of 30 degrees, they had less grade 4 IVH, as well as more survival to discharge. But then since there has been more literature coming on what the head positioning does to cerebral oxygenation, and in this recent systematic review or meta-analysis that was done, published on the cerebral oxygenation with supine versus prone positioning, really there was no difference that was found in the cerebral oxygenation in comparing the supine versus prone positioning. And then also, since that trial that I talked about was published, there has been a systematic review as well, which has also shown that the supine head positioning is not associated with less IVH as compared to any other head positioning. So perhaps there is more to IVH causation than positioning, and there is perhaps more to preventing IVH than positioning. And before I kind of go into the next theory, I just want to talk about the literature that actually kind of is supporting that other theory. So let's talk about the hemodynamic measurements and their associations in relation to IVH. So Obviously, when we talk about measurements, we have to talk about all the measurements that can be done at the bedside. So including blood pressure, echocardiographic measurements, as well as cerebral oxygenation measurements. And let's see what kind of, what lessons we learned when we looked at these measurements in relation to IVH. So hypotension is every neonatal fellow's on-call nightmare. And there is always a worry about, hypotension and brain injury, because, as I said, we care for the heart ultimately because we care for the brain. And indeed, there are studies that have shown that there is indeed an association between hypotension in the first 24 hours of life and the occurrence of any grade of IVH, as well as severe IVH, so grade 3 and 4 IVH. So what happens if we treat IVH? So in this study by Batten et al., they looked at any treatment for hypotension within the first 24 hours, and then both short-term outcomes as well as long-term outcomes. And indeed, on the first table here at the top, you see that a treatment of hypotension, irrespective of whether that treatment leads to increase in the blood pressure or not, is associated and is independently associated with severe IVH or PVL. And not just that, it is also associated with either death or any neurodevelopmental impairment at 18 to 22 months corrected age. So hypotension is bad, but then treatment is not that great either. And then on the other hand, there have been other studies that have kind of contradicted this finding. So this is the EpiPage cohort, so about 1,500 infants that they looked back within the first 24 hours and saw if the babies received treatment for hypotension or not. And again, contradictory to the previous studies, they showed that the infants whose hypotension was treated actually had improved outcomes as compared to those without whose hypertension wasn't treated. So there's going to be another talk on hypotension, I think tomorrow. So I'm going to leave the larger debate for that talk. But what I want to really stress upon here in this talk is, again, blood pressure is probably not where we need to stop at when we are evaluating the risk of IVH during the first 72 hours. There is perhaps a need for a more global and a more detailed assessment of the hemodynamic status. So how does blood pressure then correlate with outputs, with echocardiographic markers? And in this study by Kluckow, they clearly showed that there is really poor correlation between left ventricular output on the x-axis and mean blood pressure on the y-axis. So here you also see the outlier. So there is this baby here at the very end who has a lower mean blood pressure, but a really high left ventricular output. And on the other hand, there are babies with low left ventricular output with either normal or high blood pressure. So a really poor, again, marker of the left ventricular output. Is there a correlation between blood pressure and cerebral oxygenation? So here we looked at the correlation between cerebral oxygenation together with outputs, the left and right ventricular outputs with either systolic, diastolic, or mean blood pressure. And again, we saw the same. This was done in a cohort of 50 babies within the first 72 hours of life, and we showed that there was really poor correlation between these markers and with cerebral oxygenation, as well as with fractional tissue oxygen extraction. So I think one of the major challenges in really, getting a hemodynamic insights into the mechanism of IVH is the challenge in doing serial ultrasound studies. So, getting lots of echoes within the first 72 hours, just because the physiology is so rapidly changing, and which is what Nouri et al. Did in this particular study, where they scan babies every 6 hours within the first 72 hours of life. And what they found was that the babies who had IVH, which are the clear diamonds, they have an initial low LVO, or an initial low cardiac output. Similar to low cardiac output, so we know that the left ventricular output can be influenced by the presence of shunts, which means that if you have a left to right shunting PDA, your LVO can be elevated, but that does not always give you information on what's happening at the cerebral end. And that's why SVC flow, which is thought to be a more accurate indicator of the cerebral blood flow. Again, Mr. Klakau et al. Did this study looking at sequential scans again. So again, a kind of a hard study to do within the first, I think within the first 48 hours of life. In a larger cohort, so this was like 126 babies, and what they showed was that the babies who developed late IVH had a significantly low SVC flow initially, as well as this low SVC flow was also associated with a large ductal diameter at both the 5 and 12-hour mark. So again, that adds another layer. So low flow, low cardiac output, as well as a big duct. So where are we going to from here? What does that tell us? Before I talk about the duct, I want to talk about cerebral oxygenation. So there has been, I think in the last decade, as Dr. Chock has outlined, a number of studies that have actually shown consistently that IVH is associated with low cerebral oxygenation. Again, as Zach pointed out, we don't know whether it's chicken or egg, but this was one of some of our pilot work as well, which showed that the babies who develop severe IVH, which is the grade 3 and 4 IVH, that are the black lines, compared to the rest of the babies, which is the green solid line is the median, and then the green shaded area is the interquartile range. So babies with severe IVH have an initial low cerebral oxygenation as compared to those who don't. And Dr. Chock also pointed out about the threshold of 50%, so less than 50% for 1%, I think more than 1% of the monitoring period in the first 90 to 96 hours was associated with either death or severe brain injury. So again, I think this leads to another kind of piece of information, which is again, an interesting piece of information. So we have the hemodynamic, the echocardiographic side, we have the cerebral oxygenation side. And this low cerebral oxygenation can be seen as early as the first few minutes of life. So babies who developed severe IVH were shown to have lower cerebral oxygen saturations within the first 15 minutes of life, which is again the bottommost curve here, with the diamonds being the mean. And then another kind of interesting observation was suggested by Alder-Liston et al., where they showed that preceding the actual development of IVH, there is a period of high cerebral oxygenation. So again, initial low cerebral oxygenation and a later high cerebral oxygenation. I think the talk about cerebral injury is will be incomplete without talking about the duct, which I I think we don't really know much about, but there is some indirect evidence that we have from epidemiological studies, such as this one here by Selmer et al. That have shown that large PDA is associated with both any grade IVH as well as grade 3 and 4 IVH. I think what is ideal is to see how the ductal physiology changes within the first 72 hours in relation with what cerebral oxygenation does concomitantly, which is, again, as I said, a hard thing to study given the fact that we can only do ultrasounds serially. And Dr. Chock here showed, interestingly, that a hemodynamically significant duct is not associated with low cerebral saturations, but with low renal saturations. But this was not within the first 3 days of birth. So it's very hard to say how the physiology kind of had impacted the cerebral saturations early on in life during transition. So I think what we can kind of come to some plausible explanation of how the duct may play a role in the mechanism of IVHs. If for those of you who may have attended Dr. Phil Levy's talk on, I think, the first day on the immature myocardium. So we know that in the immediate postnatal period, when the heart, the LV is exposed to a high afterload from the cord clamping, and a high SVR, and the immature kind of developmentally non-compliant left ventricle is not able to respond that quickly to that change in afterload. And so that leads to a drop in cardiac output, so left ventricular output. We also know that as early as 5 hours of life, when the PVR drops, the duct starts shunting left to right. And so the left heart preload increases, but the left heart is still kind of adapting at that stage to that load, to those changing loading conditions. So the left heart output remains low, and whatever the cardiac output the body is getting, likely because the duct starts shunting left to right and the SVR drops, possibly is directed to the lower body at the expense of the brain, which is it's preductal, and therefore it's at a has higher resistance as compared to the lower body. And so the blood then kind of preferentially goes into the low resistance lower body, causing possibly brain hypoxia. As the left heart then adapts to those loading conditions, sorry, there is a code. So as the heart adapts to the loading conditions, which is the preload coming from the PDA, the left ventricular output increases. But at this time, because the brain, as I said, is a preductal organ, the brain then actually gets high or raised perfusion or increased perfusion as compared to before, in comparison to the lower body, because the duct will be shunting the blood back to the lungs from the lower body. So this kind of can explain why the PDA may play in the role in this hypoxia reperfusion kind of injury. So do we have evidence on what happens if we treat the ducts early? Does that decrease IVH? I think we have indirect evidence. So the TIP trial, which showed that prophylactic indomethacin causes a decrease in the incidence of IVH, severe IVH, also showed decreased in the incidence of patent ductus arteriosus requiring treatment or surgical ligation. So I think, if we kind of put all the pieces of the puzzles together, what we have so far, the different pieces are, we have low left ventricular output, we have low SVC flow, we have low cerebral oxygenation, possible a higher oxygenation later on, and then perhaps the PDA is playing a role there as well. So how do we put all of these things together? So we know that preterm birth is associated with hypoxic state because of the inflammation, infection, placental insufficiency. Respiratory insufficiency also contributes to hypoxia. That then leads to cerebral hypoxia. We talked about how the heart adapts to the loading condition, how the initial low or maladaptation of the heart can further then exacerbate the cerebral hypoxia. We talked about how as the heart adapts and as the PDA shunts left to right, the cardiac output increases and that causes reperfusion, therefore leading to intraventricular hemorrhage. Obviously, these are speculations, these are theories. What we really need at this stage is more research on these mechanistic insights, because I truly believe that prevention comes only after true understanding of the mechanism. We need early biomarkers that we can identify and treat early before any irreversible damage happens, and whether those are modifying one particular component, whether that's modifying hypoxia, whether that's modifying the reperfusion, whether that's modifying the duct. I think we are still not there yet. Whether it's therapies to target autoregulation. So lots of unanswered questions there, and I realize that I'm leaving the audience with more.
I think, and I'm not sure whether it's just for me, but it seems like Purva is freezing. I would like to introduce the next speaker. I have the pleasure, and of course, thank Purva, but I'm not sure whether she can hear us at this stage. So I have the pleasure to introduce our next speaker, and that's Dr. Regan Giesinger. She's a staff neonatologist and associate professor of pediatrics in the Division of Neonatology at the University of Iowa. Her research or areas of academic focus are the hemodynamics of critically ill neonates and the relationship between cardiovascular and neurological outcomes, particularly amongst neonates with perinatal hypoxic ischemic insults. And Regan will be presenting on HIE physiology. So hi, Regan, nice to see you again, and the floor is yours.
Hi, can you see my title slide?
Yeah, it's still in kind of presenter view, so or not in presenter view. Sorry. We can.
Do you see one slide or two?
We see two slides. So we see your.
Better?
Yeah, that looks good. Thank you.
All right. So I would just start by saying thank you for the opportunity to speak. I'm going to change gears just a little bit, but not very much from the speakers before me that I have the pleasure of going after. So first of all, just a little brief update. What is HIE? So HIE is the terminology that we use to describe the brain injury, which occurs when fetal compensatory mechanisms to impaired cerebral blood flow fail. It leads to cellular energy failure, resulting in excitatory neurotransmitter release, the production of reactive oxygen and nitrogen species, calcium and sodium dysregulation, and other pathways. Together, all of these stimulate the production of inflammatory mediators, which create a secondary phase of injury in which cellular apoptosis occurs. The other thing that we know, just as a refresher, is that between 1998 and 2010, 7 randomized trials which included 1,214 neonates with moderate to severe HIE, randomized babies to moderate therapeutic hypothermia or normothermia. And this is one of the most well-studied interventions in neonatology, demonstrating that for the composite of death or major disability, therapeutic hypothermia is favored with a number needed to treat of 11 for improved mortality and 8 for a lower burden of neurodevelopmental impairment in survivors. So we know this is a very effective therapy. Mechanisms of injury are twofold, as I previously mentioned. There's the initial phase of necrotic cell death, and then the secondary phase of secondary energy failure, where therapeutic hypothermia is thought to exert its effect. And there are a number of other adjuvant therapies which have been and continue to be investigated as brain protective strategies to augment the efficacy of therapeutic hypothermia. What it's really important to remember is to take this back a step and think about how therapeutic hypothermia actually modifies brain injury. And the mechanism of neuroprotection is probably very complex and multifactorial. One of the major thoughts is that a reduction in brain metabolism leading to lower oxygen utilization, modulation of cerebral blood flow, and a reduction in edema and inflammation are some of the sentinel features. So I'm talking about this after we've talked about this very effective intervention, but it's really important to remember that unfortunately in the current era, there are still about a little less than half of babies who either die or are left with neurocognitive sequelae despite optimal application of therapeutic hypothermia, making it important for us to think about other contributors that we can modify. So one of the things we often don't consider is that hypoxia ischemia is often not a single time point event. Ongoing impaired cardiac output after the initial stabilization and hypoxemia after resuscitation may continue to contribute to necrotic cell death, with other cells entering the latent secondary energy failure phase at different stages. In pre-cooling studies, we've identified that the pattern of brain flow in several major cerebral arteries, so looking at the middle cerebral artery, the ACA or the basilar artery, have been shown to be associated with adverse outcomes, either low resistive index, where the diastolic flow is very high, or high resistive index due to absent diastolic flow, are more prevalent among patients with more severe injury. And as was previously mentioned, there is an important correlation that has been identified between the pattern of blood flow to the middle cerebral artery versus other systemic arteries, which can be seen in these graphs. In the left panel, you see that the dark black graph velocity escalates over the course of the first 72 hours, suggesting that more blood flow is associated with a greater degree of brain injury, which you don't see in other systemic vessels. However, really important to understand in this disease and all diseases where we're talking about the hemodynamics in the brain is that we really need to have paired data comparing the brain and the systemic circulation at the same time to know whether some of these things are cause or effect. This is another study that came out of Vancouver in about 2010, which demonstrates that patients with an abnormal brain MRI had about 70% of their cardiac output at 72 hours of age towards the preductal circulation. And this goes along with the Doppler studies that I just showed, showing higher middle cerebral artery flow on the third day in the more severely injured babies. And this finding, in combination with the Doppler findings, suggests that hyperperfusion may actually be associated with worse outcomes. So where do we take this now? We know that abnormal cerebral blood flow is a consistent finding in babies who have adverse outcome. We know that cardiovascular dysfunction, either as evidence of transient myocardial ischemia or defined as need for vasoactive therapies, et cetera, is very common. And we know that we have no well-studied standards. So there isn't one uniform approach to this across the field of neonatology. And so this represents an important window where further research and further clarification of mechanisms and understanding may actually present a window of opportunity to make a difference in these babies' outcomes. So this is a putative diagram which explores many of the potential contributors to abnormal outcome via either ischemia or reperfusion injury. And if we accept the premise that cerebral blood flow and oxygenation are modifiable contributors to disease, then it becomes really important to understand how all of these things interplay. And as you can see, this is very complex, which for a researcher is both exciting and challenging, and makes it very difficult in the clinical situation to put these things into practice. One of the other things that's really important is that although the connections and the potential mechanisms of injury are very complex, clinical research into this field is extremely challenging. Most of our clinical tools are way too simple to really be able to give us an idea of how all of these things are fitting together. And as you've heard previous speakers say before, there are a lot of different ways to do things and really not good standards as to how we can compare our findings. And all of these things may actually be either dependent or independent on heart function, which we can only measure intermittently. So just to take the very most basic steps. So if we ask a simple question, what is abnormal blood pressure in this patient population? This seems like a pretty simple thing to define. But when you ask people, so this is a survey that we did a couple of years ago, asking people in 71 academic NICUs across North America, what is an abnormal blood pressure for a patient with HIE. And you can see that we got 17 different definitions of hypotension. And with this degree of clinical heterogeneity, let alone this degree of heterogeneity in research, it's going to be extremely hard for us to all be speaking the same language. And we need to make sure that we're on the same page before we try to answer any major questions. Also important is, although many of us recognize that echocardiography is a very useful tool in patients who have cardiovascular insufficiency or potential heart dysfunction, 40% of centers in the US don't even routinely request an echo if a patient is being treated with vasoactive support. And so many of us are doing things blindly. And while ejection fraction is commonly reported for the left ventricle among those who do get echoes, only qualitative assessment for the right ventricle is really reported in most centers, and most places are not using things like right ventricular output. What we know is that echo does identify cardiac dysfunction, and cardiac dysfunction is fairly prevalent, both by conventional measures like shortening fraction and more sophisticated measures like global peak longitudinal strain of the LV or strain rate and torsion. But there is no association that has been identified to this point between LV dysfunction and neurological outcomes. So this brings me to one of my areas of academic focus, which is in the role of the right ventricle in patients with HIE. So you can see from this, you don't have to be a four-year trained echocardiographer to be able to recognize that this apical four chamber on the right of the picture here is abnormal. This was a term infant who had a little bit low blood pressure, who I was asked to see as a hemodynamics fellow. And I was scanning this baby and was petrified that I was missing hypoplastic left heart because her right ventricle was so large and dysfunctional in comparison to her left. And so this brought us to ask the question, why could the RV be particularly impacted in this disease process? And I have done a lot of reading into this and came up with a few kind of sentinel reasons. There are a lot more that I won't go through, but the first one is that the right ventricle has a higher metabolism and a higher blood supply than the left ventricle because of its very important role in transitional circulation. It's the dominant role in fetal life and the dominant role in the neonatal transition, meaning that it requires more substrate in order to function. The other thing that's very important is because the right ventricle is wrapped around the left ventricle, the ratio of circumferential radius to wall thickness is much higher than that of the LV, meaning that for an equal amount of afterload, an equal amount of pressure to pump against, the wall stress on the right ventricle is dramatically higher than the wall stress on the left ventricle, also meaning that it will need more substrate and is more vulnerable. And then really importantly is that the coronary flow is particularly susceptible to problems because the left ventricular output becomes low when you have heart dysfunction and low cardiac output, which means the aortic root pressure is low. And at the same time, the central venous pressure in the right atrium becomes high and the RV cavity pressure becomes high. And so the gradient to flow from the aortic root to the coronary sinus, the right atrium and the right ventricle is much lower, therefore resulting in an intrinsic less substrate being delivered. So it has both more substrate requirement and less substrate delivery than the left ventricle. And just to take a step back for 1 second to echocardiography assessment, it was really important when we were embarking on this work to think about why this question had never been kind of asked before. And one of the reasons is because people were really not looking at the right ventricle with any degree of precision. So eyeball assessment of the right ventricle, particularly for mild or moderate disease in terms of function, dilation, and then also in this study, we looked at septal flattening, is quite poor. And it's not until the extremes of disease that looks like that baby that I showed you that people are reliably able to identify dysfunction. And now term neonates have had normative data published, making this much easier to study. So what we did, we designed a prospective study looking at basically 3 aims. 1, to look at RV performance over time. 2, to look at the relationship between RV function and short-term or long-term adverse outcomes. And 3, to explore whether abnormal cerebral hemodynamics, as we discussed with respect to the Doppler studies, are related to a supply or a demand problem. And this was just a pilot aim that we were working on. So we performed this study. Just over 50 infants were recruited, which had multiple time point echoes on the first day, just before rewarming, just after rewarming, also had NIRS and serial clinical exams with blinded echoes. We performed a comprehensive protocol. This is just some of the examples of some of the things that we looked at. And what we identified was that the RV measurements for the first aim, the RV measurements were the lowest at 24 hours in both groups and came up to the normal term data by about 96 hours on blinded evaluation. And this applied to TAPSE and also TAPSE-Z scored for age and fractional area change. What we also identified was that because the right ventricular measures were substantially lower than 2 standard deviations below the mean, we hypothesized based on this that the right ventricle was the more impacted ventricle and that babies with an adverse outcome were more likely to have abnormal RV function, and that the LV changes that we saw, which as you can see were present but minor, represented ventricular-ventricular interaction. Our secondary aim, we chose the most related echo, so the 24-hour echo, and we used that to interrogate the relationship of RV function, specifically TAPSE and fractional area change, to a composite outcome of death or abnormal MRI defined by a standardized scoring system. And then we adjusted this for the effect of illness severity and severity of encephalopathy. And what you can see is that all measures of RV function that I presented for you here, the top 2 are TAPSE and RV fractional area change, were significantly lower in the babies who had adverse outcome as compared to those who had a normal outcome, while the LV ejection fraction was similar between both groups. And as we expected, the cerebral regional oxygen saturation was higher in the adverse group, and this is in keeping with previous literature on this subject. We then went on to look at a composite of cerebral palsy, or 2 standard deviations below the mean on the Bayley-3 at 18 months, and showed that similarly, if you have a TAPSE of less than 3 at 24 hours of age still, your likelihood of having an abnormal developmental outcome is predicted with an area under the curve of approximately 0.9. And in fact, based on the predicted probabilities curve that you see on the right here, a persistent TAPSE of less than 4 at 24 hours of age was associated with an extremely high likelihood of adverse outcome at your developmental follow-up evaluation at 18 months. And so this brings us back to the fact that we have an association, but is this really just a useful prognostic tool, or is this actually an area to improve outcomes? And we don't know that yet, but it certainly brings to the forefront that more work needs to be done in this area to look at whether early impact on RV function can actually give you the possibility of improved outcomes in the longer term. Finally, our third aim for this study, and then I'll just go on to a couple of other works, was to look at the association between cerebral regional oxygen saturation and left ventricular output to speculate upon whether or not this represented luxury perfusion, in that the brain was getting lots of blood and therefore didn't need to extract much oxygen, or whether this was a primary problem with the organ, and no matter which blood the brain was getting, it was going to extract less because it was working less well. And what we found was the latter. These babies had high regional cerebral oxygen saturation in the adverse outcome group, suggesting that they were extracting little oxygen and associated low cardiac output at the same time. This is just another way to look at this. We plotted on the left graph the middle cerebral artery resistive index, which is a marker basically of perfusion pressure with cerebral regional oxygen saturation. You can see the R squared is completely almost close to 0, with dots scattered everywhere, suggesting no relationship at all. And then we plotted left ventricular output against the same regional cerebral oxygen saturation and found an inverse relationship, which suggests that lower extraction is occurring despite lower supply. And again, the R squared was low, but it was trending in the opposite direction to luxury perfusion. So another couple of important points when we're trying to study things in this area. Now that standard of care includes cooling, it's really important that we understand whether cooling itself modifies RV function. And so what we did here was we took a small cohort of babies who had pre and post cooling echoes. And the post-cooling echoes were done within 1 hour of attaining target temperature, and no other cardiovascular or other things were changed in between the first echo and the second echo between these patients, aside from temperature. And what we saw was that markers of pulmonary vascular resistance and pulmonary artery pressure, so the systolic eccentricity index, or the degree of septal flattening, and the pulmonary vascular resistive index, the amount of the time to peak velocity relationship, and the presence of a notched PA Doppler all changed significantly with an increase in pulmonary artery pressure and vascular tone following therapeutic hypothermia. And as expected, the outputs of both right and left ventricle went down in keeping with the literature, which is on the basis mostly of heart rate, but also of VTI. But importantly, the measures of heart function that we studied, TAPSE, et cetera, demonstrated no significant change. And importantly, the ratio of TAPSE to PAAT in these patients, so a marker of coupling of afterload to RV function, was preserved, suggesting that the changes in RV were proportional to changes in afterload, and that there was no associated dysfunction being elicited here. Important though, so this is some clinical data from the same cohort, looking at the fact that individual patients may actually respond differently to cooling. And you can see on the right, the systolic eccentricity index goes up, and the left is a graph of oxygen requirement. And you can see that the babies who started out less than 40% oxygen really didn't change that much. But in the babies who were requiring more than 40% oxygen to start, many of them, the 3 of them, had a significant increase in FiO2. And this just suggests that we should be cautious when we're inducing hypothermia for babies who are already in a lot of oxygen, because we know that pulmonary vasoconstriction is associated. And this is another example of a baby who demonstrates that temperature alone is a really important modulator. There is animal data that goes with this, but this is a clinical example from a patient we saw. So this is a term infant, again, 37 weeks, who had an emergency C-section for nuchal cord, quite poor APGARs, quite poor cord arterial gas, and an opening lactate of 20. We were asked to see this baby because of her FiO2 requirement in the 40s when she arrived, and the fact that we standardly screen all babies with HIE when they're admitted. So this baby had an initial temperature at the time of evaluation of 35.8. And you can see from the arrow there that that orange, which is her PDA, is basically all left to right. She was in 40% oxygen at the time with a blood pressure in the 50s on 30s. And then the team proceeded to cool her. And you can see from the EPIC screenshot at the bottom that the blood pressure really didn't change. But over the course of the period of time where she went from 35.8 to 33.1, her FiO2 went up from 40 to 100%. And you can see that her ductus is now almost all right to left. And this is just a cautionary tale supporting the animal literature that for every decrease by 1 degree Celsius, you get a 1 to 2% increase in PVR. And we should just be cautious about that. So moving on to treatment. If we think about cardiovascular treatment in babies with HIE, in that same survey that I spoke about earlier, we asked about people's first-line agents, and dopamine was by far the first-line agent, whether the patient had just hypotension or hypotension and hypoxemia. We know that dopamine increases blood pressure in asphyxiated newborns. And so when we're thinking about the relationship between blood pressure and brain injury, it's important to understand whether we're doing something good or something bad here. There's been a couple of studies suggesting that treatment with inotropes or vasopressors specifically is associated with more likelihood of adverse outcomes. And this study actually suggests that treatment with dopamine is associated with an increased risk of the composite of death or abnormal MRI with a P of 0.03. The problem with this is we don't know if this is cause or effect. And does correcting blood pressure, overcorrecting blood pressure, or leaving blood pressure the same have any impact? Or is this just an association? So here's one example of a way that we can try to figure this out. This is a study by Kovacs et al., where she compared 2 cohorts from 2 different centers. In center A, there was an inotrope predominant approach, so first-line dobutamine. Lowest blood pressures were recorded in this cohort, about 44/25. There was some permissiveness to hypotension if the baby was otherwise clinically improving. And despite low blood pressure, there were about 49% untreated patients in the cohort. There was echo-guided care to help to facilitate that decision-making. And there was not very much hypertension in that cohort compared to the other one. In center B, there was a vasopressor predominant approach, basically which said if the mean blood pressure is less than the gestational in weeks, dopamine should be started. So there were very few untreated hypotensive babies. There were more hypertensive babies, and there was much less echocardiography because it wasn't built into the approach at that center. So what they found when we compared the patterns of brain injury, we found that there was a similar rate of death or abnormal MRI, but that the patterns were different, and there was more focal, multifocal lesions, more mild lesions in the dobutamine focused tolerant echo-guided group versus more basal ganglia injury in the dopamine more aggressive treatment group. And again, it's hard to know the cause and effect of this, but this actually suggests that there might be a lower exposure to, or a more prolonged exposure to low cardiac output because of the afterload increasing effect on a patient who intrinsically has heart dysfunction, and the greater risk of hypertension may actually be associated with a greater risk of reperfusion injury. This is really just suggesting caution and using thought about what's the intrinsic problem when we're approaching treatment for these patients. Oops. The other thing that's really important to know is that normal blood pressure is actually a really poor surrogate for normal heart function. This is another cohort of babies which was either treated with an inotrope to correct blood pressure or not requiring of an inotrope to have a normal blood pressure. And you can see that in the top graph on the left here, the blood pressure is very similar between the two groups at the time of the echocardiography that was performed in this study. However, when you look at the RV function measurements, the TAPSE was actually low in both groups and substantially lower in the inotrope treated group, as was the right ventricular fractional area change. So there was pretty substantial heart dysfunction despite either treatment for and correction of blood pressure or no need to correct blood pressure in the first place. And when you plot the mean blood pressure or the systolic blood pressure, mean on the top, on the bottom, sorry, two graphs, and systolic on the top two graphs with left ventricular output and with TAPSE, as a surrogate for RV function, you really find that there's absolutely no relationship between these two things. And this really highlights the fact that we really should be doing echoes in this patient population. And in particular, we should be doing echoes on that group of patients that are being treated with cardiovascular agents, because we really don't know what's going on under the surface. One further quick word about treatment. We know, we've talked about it, we'll talk about it more. Milrinone is a great drug for pulmonary hypertension, which many of these babies have. It has many documented good effects. It improves oxygenation, it improves function. But there are some caveats to using medications in the HIE cooled population that are really important to remember, not only when we're treating these babies clinically, but when we're thinking about research in this population. This is a study that we conducted a matched group of with three groups. The green is a cohort of age-matched patients with HIE who were cooled. The purple is a group of age and illness severity matched patients who had pulmonary hypertension who were treated with milrinone. And the red is a group of patients who were both treated with therapeutic hypothermia and with milrinone. And what you can see is that the two graphs on the left represent the blood pressure, and there's a very rapid decline in the red group over the first couple of hours after milrinone was started, which gradually crept back up over the course of about 24 hours as the drug was either stopped or inotropes and vasopressors were escalated. Whereas in the graph on the right, what you can see is that while the purple team, the ones who had pulmonary hypertension and got milrinone, gradually improved in their requirement for vasopressors, and the HIE babies didn't change, the babies who had therapeutic hypothermia and milrinone had a dramatic escalation in their inotrope score. And this actually just goes back to the comments that ischemia reperfusion injury and a dramatic increase in the need for vasopressors may not be a good thing for these babies' brains, and that certain drugs which may be metabolized or cleared in a different way, which we've seen already with drugs like morphine, really should be considered very carefully in this population. I'm just going to give you one quick comment here about babies who I've talked all about the RV, but it's not always the RV. This is a classic patient who we identified because we screened. What we found was that the left ventricle itself was completely dead, and the RV was kind of relatively spared. And this baby had an occlusive left coronary artery thrombus. And the reason that I bring this up is that when you see something weird, remember that HIE is not always a perinatal event caused by pregnancy or the placenta. weird postnatal things can happen, and pattern recognition is really important. Just as take-home points, I see Gabriel has popped up here, but all I really want you guys to come away from this with is that the interaction between the heart and the brain is important. In HIE patients, we don't really understand it well, but we're starting to make progress. It's really important not to forget about the right ventricle, and all things are off the table with HIE because you've changed their metabolism and you've changed their organ function. And so you need to remember that we need to keep all those things in perspective. Thank you to the team.